والسلام على أشرف خلق الله أجمعين. Today, inshallah, we are going to talk about abdominal examinations and steps in abdominal examinations. The first step from outside. Once you got inside the room, you are going to do W. The first W is wash your hands. The second W, go to the wall. In the wall, if they said to you the patient having hypertension, examine his abdomen, that means this is polycystic kidney. Hypertension in abdomen, most likely polycystic kidney. Repeat this maneuver of ballotomy 2 or 3 times. Do not miss the masses. The second thing, if the patient complains of fatigue, examine his abdomen, that most likely you are dealing with a chronic hemolytic anemia. Is that clear? Then after that, I will come to the patients. Come with me. Hello, good morning. My name is Dr. Adam. I would like to examine you. During my examination, if you feel any pain or discomfort, please let me know. Is that okay? It's better to put this on one side, and I will come back 2 steps away from the patients. General look, the general look. Then after that, can I have a look to your hands, please? Can I have a look to your hands? Then I will do like this. Kida, this for clubbing. If there is any element of clubbing, I will do like this to look for the window. Then after like this for leukonychia. Then I will check the ball for palmar erythema. Then I will do my hand like this for Dupuytren's contractions. That means I have 2 in nail or 2 in ball. 2 in nail, 2 in nail, clubbing and leukonychia, whitish nail, leukonychia, whitish nail. 2 in ball here, palmar erythema and Dupuytren's contraction. Then after that, by what? By flaring therapy. Like this. In nail, in the hand, I have a clubbing, leukonychia, palmar erythema, Dupuytren's contraction, and the last thing by flaring therapy. Then I will look to the forearm from this side, from the forearm from this side to pick up any fistula. If there is any fistula, you have to do 3 steps. Step 1, to look for an inspection for any needle marks. Step 2, to put your dorsum of the hand on it to pick up thoroughly. Step 3, to put your stethoscope on it to pick up burui. Like this, to pick up burui. Is that clear?
Yes.
Then here I finish the hands. I will come back to examine the patient from above down. Focus with me here. I'll face, the neck, the chest, the abdomen, the lower limbs. The face. No need to bring the face of the patient. Focus with me here. The face in the form of jaundice and balloon. Then the mouth. Then within the same level of the face to pick out wasting of the temporalis muscle and parotic in lung. Then the mouth. Open your mouth to look for any mouth ulcer, and I will ask the patient to do like this, to pull his lower lips down to look for any gingival hyperplasia. Then I will look to the neck for any raised JVB. Then after that I will come to the chest. To the chest, focus with me here. I will look for what? For any spider nevi, for any gynecomastia, for any loss of axillary hair. Focus with me here. 3 in the chest. Yalla, mention it. Spider, nevi, gynecomastia, and loss of axillary hair. Then for gynecomastia, don't palpate for gynecomastia unless there is protrusion of there is a large breast on us to look for the firm edges. Is that clear? And take permission from the patients and from the examiners. Excuse me, I need to palpate for gynecomastia. Excuse me, it might be a little bit discomfort. Then after that, I will come to the abdomen. In the abdomen, I will do full exposure of the abdomen for any scar, for any visible veins. Then after that, I will come to the end of the lower limbs. To the end of the lower limbs, I will look for pitting edema. Do you have any vein? Can I press? Press while my eyes on the eye of the patient. Then I will ask the patient 2 orders. Take deep breath. Focus here. Take deep breath for any bulging. Then can you give me a cuff for any hernia? Is that clear? You perform the end of the bed. After I finish the hand, what is my journey? Jaundice, balance, temporalis, waist, mouse for two, mouse ulcer being given higher, lazy or glossitis, then the neck, then the chest, then the abdomen, for a scar visible vein, then the lower limbs, for what? For breathing edema. Ask the patient to order, can you give me a cup and take deep breathing. Then I will come back to the abdomen. Once you come to the abdomen, you have 3 sittings. The first sitting, excuse me, can I make the bed flat or supine position, excuse me. Then I will make the bed flat, supine position. This is the first sitting, to sit the bed flat. The second sitting, to sit on the same level of the abdomen of the patient. The third sitting is to ask the patient, do you have any pain? No. In case that if you feel any pain, let me know. I'm going to feel your tummy. If you feel any pain, let me know. Then I will do superficial like this. Superficial, not like this, like this. Is that clear? Then after I finish the superficial, I will come while my eyes on the eye of the patient. Focus with me here. I will do superficial while my eyes on the eye of the patient. Because in superficial, I'm looking for 2. For tenderness and mass. And the tenderness, I will see it on the eyes, on the face of the patient. Wallahi, if the examiner, he notice you doing superficial palpation, while your eyes, not on the eye of the patient, they will minus you. Take care from this. 3 sittings. If you minus any one of these sittings, they will sit it for you in the feedback. Sit the bed flat. No abdomen done while the patient in 45 degree. Number 2 is to have to be on the same level for superficial palpation only. Number 3 is to sit your eyes on the eye of the patient. Then I will come back to the deep. It's better to come from this side, don't bring the face of the patients. The deep palpation I have the right lobe of the liver and the left lobe of the liver. The right thing is to come laterally. Don't bring your fingers towards or to reach the umbilicus. No, wrong. Come from this area laterally, while your hand should be in oblique. Not like this, not like this. It is not like this. This is wrong. It is not like this. This is wrong. It is oblique like this. Nafas, deep breath, like this. Focus with me. I will breathe while his abdomen is relaxed. Relax. While the abdomen is relaxed, I will put my hand down. Then I will ask the patient, take deep breath. By taking deep breath, he will push the diaphragm down to bring to me the liver in my hand here. While I'm waiting for the mass here. You got me now? Huh? Nafas. Relax. Nafas. Relax. Don't relax. I will press while his abdomen in relaxed position. Then I will ask him to take deep breath. Nafas. While he is taking deep breath, he will push the mass down to me to touch it. As soon as I touch it here, as example, I will take around 3 fingers below the costal margin, which is smooth in surface, yes, dull in percussion. Then I will come to bring the upper margin of the liver from up. Resonant. Here it become what? Dull. Then I will ask him, take deep breath. نفس عميق. اكتمه. Keep it. Resonant. Make it normal. It become what? Dull. That means I am in the upper border of the liver. From here till the costal margin here around 4 fingers. From here around 3 fingers. Am I right? That means the liver span is 7 fingers. That means there is hepatomegaly palpable. 3 fingers below the costal margin, which is smooth in surface, dull in percussion, not tender. Sudden. Smooth, dull, not tender. Smooth, dull, not tender. Smooth in surface, dull in percussion, not tender. With liver span is 14 centimeters. Is that clear? Go back down. If it is shrunken liver, I will come like this. Imagine that it is shrunken liver. There is no any liver here. I will come back from above. Resonant. Here it become what? Dull. Take deep breath to make sure this is the liver and keep it. Resonant. Make it down. That means I am in the upper border of what? Of the liver. So as to not miss these points, I will calculate from the angle of Lewis. This is the second intercostal, third intercostal, fourth, and this is the fifth intercostal space. That means this upper border of the liver in the fifth intercostal space. Then I will come back from down. Resonant, 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 resonant. Here it become what? Dull. Then I will calculate from this area to this area the liver span around, as example, 6 centimeters. Then I will say to the examiner, I could not palpate the liver. The liver span is 6 centimeters. Is that clear? Focus with me here now for what I finished the dilemma of the liver. Imagine that I felt in superficial palpations, I felt the left lobe of the liver. Come here. Before, if you remember in the superficial, I felt there is mass here. You felt it. Imagine that. What you will do, you will finish the right lobe of the liver by this maneuver. You finish it, then I will come to the left lobe of the liver. Take deep breath. Take deep breath. Take deep breath. Around 3 fingers below the xiphy sternum, which is smooth in surface, yes, and dull in percussion. To sum up for you, some patients, especially here, some patients, you might get that they have even shrunken liver with enlarged left lobe of the liver. Take care from this scenario. You got me now? By superficial palpation, you are going to pick up the left lobe of the liver. Don't miss it. Go to come to it. When you come to finish the right lobe of the liver, don't forget to palpate for the what? For the left lobe of the liver. Then I will come back to the spleen. No, from this side only. Nafas. Again deep breath. Again deep breath. I didn't come like this. I came oblique. Nafas. Nafas. Deep breath. Yes, breath. Breath. Imagine that I palpate the spleen here. I will come back to around 4 fingers below the costal margin. Smooth in surface. Smooth, firm. No splenic notch, cannot get above it. Yani even if you got above it, there is no ending for it. Yani cannot get above it like polycystic kidney. Then I will percuss above it. It is dull in percussion. Even you are going to go down for the splenic bed, which is 9, 10, 11. 9, 10, 11. Intercostal space, mid-axillary line. This is a splenic bed. Yes, dull. Look here, one examination of this man. He has got splenomegaly, palpable, 3 finger or 4 finger below the costal margin, which is smooth in surface, dull in percussion, not tender, cannot get above it, move with respiration, with splenic notch. Or if you did not get splenic notch, say, don't bring it in your tongue. Or I could not get it. Don't say there is no splenic notch. You are not ultrasound. Is that clear? Then after that I will come back. Imagine that you didn't get spleen. Tilt the patient to the right side. Then come from this side. I will support the patient like this. Then I will ask the patient, nafas. Again, nafas. Deep breath. Deep breath like this. The important things is to put your hand here. Is that okay? Don't come from here. Nafas, again, nafas, again, deep breath till you catch it. When you catch it, around 3 fingers below the costal margin, dull in percussion, smooth in surface. Is that clear? Then I will come back to the polycystic kidney. Polycystic, put here. Put your hand here. Don't put it like this. Sometimes not come from my experience in this field. Take care from the face of the patient. I will come oblique like this and I will do like this. Then the first thing, if you come like this, it not usually come with me from my experience. Like this, 2 together, no. To put this first and come back also, no. The first thing to come oblique like then slightly rotation and come down. Your finger should not reach the umbilicus here. You got me now? Don't reach the umbilicus. From here, around 2 fingers or 1 finger from the umbilicus, then come like this. Press first, then come from down. Focus here from down. From down, my index finger will be in the lower rib of the patient. The lower rib of the patient. Don't reach the vertebral column down. If you reach the vertebral column, you will not get it. Like this, then I will do it while my eyes on the eye of the patient. Focus with me here from that side. I will do it, focus here, while my eyes on the eye of the patient. Then I will, the same hand here, I will bring it where? Here. Then I will do it while the eye on the eye of the patient. Don't do ballotomy in case that your eye is not on the eye of the patient. Then after that I will come to the ascites. Focus with me. Liver, spleen, kidney. Liver, spleen, kidney. Liver, spleen, kidney. Liver, spleen, kidney. This is the palpation of the abdomen. Then I will come to the ascites. Imagine that this patient having ascites. Come here. The water or the fluid will be on the flanks of the abdomen. The center of the abdomen will be what? Air. Am I right or not? Then I will percuss from above down. Resonant, 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 resonant. Then I will come back, resonant, resonant. Here it will become what? Dull. Then I will shift the patient to that position. The water immediately will go where? Down. Then I will percuss again, it will become what? Resonant. That means this patient having positive shifting dullness. That means there is evidence of ascites based on positive shifting dullness. If it is not changed, that means this is mass or this is muscle or fat or anything. That means this is negative shifting dullness. The mistake is no need to shift the patients. In case that everything is resonant, no need to shift the patients. Is that okay? If it is all dull, no need to shift the patient. Clear? If there is mass here, don't shift yourself to the area where there is mass. Shift your hand to the area where there is no mass. Then after that I will bring the auscultation. The auscultation I have fixed area. Xiphoesternum for venous hum. Because umbilicus this side and this side for bruit of renal artery stenosis. And right iliac fossa for bowel sounds. Clear? Then this is a fixed area. Modified area, if there is mass here, there is mass here, there is mass. Any mass, any area where there is mass, you have to what? To auscultate above it. Depend on the mass sign. Then after that, I will ask the patient to sit forward. When he sit forward, I will check for the lymph nodes. I think the lymph nodes is clear. Am I right? Submental, two sub. Submental, submandibular. Two anterior. Anterior auricular, anterior cervical. Am I right? Anterior cervical, anterior auricular, posterior auricular, posterior cervical, and occipital, and the last thing, supraclavicular. To sum up for you, to present the hepatomegaly to the examiners, one examination of this patient has hepatomegaly, palpable, 3 finger below the constant margin, which is sudden, smooth in surface, dull in percussion, not tender. Liver span is 14 cm. The normal liver span between 8 to 12 cm. Less than 8 cm is Shrankenherz. More than 12 cm is hepatomegaly. Imagine that present splenomegaly to the examiner. On examination of this man has splenomegaly, palpable, 8 cm below the constant, which is sudden, smooth, but not tender, cannot get above it, move in this direction. Yeah, if there is ascites evidenced by shifting dullness or through its serial. I didn't talk about it, I will talk about it later on. Is that clear? Yes. After this we are going to discuss how to present the findings. Is that clear? Yes. The maneuver is clear? Yes. Thank you.